Thank you. I invite Dr. Krishna Prasad to give his talk on how to teach professionalism and communication to our trainees. And with your permission, the two young educators, I think we'll take up Dr. Apurva's case and then break for lunch because we're running behind schedule. And Dr. Rolika, you're anyway part of the next session, so we can start with your case. Thank you.
So, thanks Dr. Meenakshi, Ophthalmology Foundation, ERC AOS for the opportunity. Thanks for allowing me to learn so much from this session. So, we teachers should learn one thing, in my opinion, that we have to a great extent become irrelevant in the present context or in the conventional context. Because our students are spoiled for choices. There's a deluge of information out there. I'm not saying it in the negative sense, because the students can opt out for the best teachers globally. My students can probably log on to reels of Dr. Pranesh for the thing that they want and sleep in my class. So there is no need for them to really seek the guru in the way that we want. So obviously, medical knowledge or the kind of procedural skills, because they can have YouTubes, they can see skills, they can learn so much from the experts in the field. So in this context, these 6 competencies, what ACGME tells, the patient care, the medical knowledge, all these things actually can be sought on a parallel ground, but the professionalism and the communication skills is something, you really need to actually work on that. Because with this, whatever kind of student that we have been discussing so far, the present generation Z students, they are, I would say, dumb, socially awkward, non-communicative. They can't pick up the non-verbal clues from the patient or the other person, and they cannot read emotions. So they are almost in themselves. So this is an obstacle for an effective patient care. See, we have a lot of conflicts because they're not repairing a machine. They're repairing. So you don't have to talk to a machine before you repair. Or you don't have to ask how good morning to the machine, nor ask the feedback how the machine felt after being repaired. So they're talking to a human being, a fellow human being. So this is something, that big obstacle that we are seeing, because it's about the competencies. Are we developing the competencies to really complete this picture of creating a very professional and eye care provider who can actually help? So what is professionalism? It's a big definition. It's a habitual, so they have to do it every day, and a judicious, okay, the use of communication. So there's a communication in professionalism, knowledge, obviously, the wisdom, the technical skills that they should know, clinical reasoning, obviously they have to connect the dots, and use of emotions. This is very important. They cannot be non-emotive. So you have to actually show emotions, good or bad, in the right context and right content. Values, you need to show your values. That's very important in the personal context. And obviously they need to reflect on their day-to-day behavior and do necessary correction in their daily practice for the benefit of the individual. So this is what is the actual definition says. But to kind of split it down, for a postgraduate who is in training, basically they need to get committed to their professional competence. See, learning to actually do things right, whether it is the skills or the procedures, is actually professionalism. See, if somebody is not doing their duty properly, if they don't know how to do a cataract surgery, how to do a sac syringing, it is actually, they are not professional. They need to. So it's our duty to actually make them learn. It's their duty also to learn. And the honesty with patients. See, there's a complication, there's a posterior capsular damage, and there's a drop, there's epinucleus, or some nucleus pieces have gone down. You have put the eye hole in the sulcus. What will you tell the patient? Are you honest with the patient? Will you say there is a problem, try to get around that? Or will you say everything is fine, you want to sweep the dust under the carpet? So this is also a professional behavior that we need to actually see. And students come late, they don't follow instruction, they don't write documents properly, they don't document, so they don't follow the prescribed SOPs of the hospital. So this commitment to the institutional discipline, because not everybody is self-driven, we need to put this discipline in place and also monitor it. And patient confidentiality. There are a lot of students I have seen, like, referring, this HIV positive patient should be seen last in the OPD. See, they are so, vocal about certain things, trying to give the patients, personal details. and basically maintaining the appropriate relation. This is also very important, the right kind of use of touch or the non-verbal communication with the caretakers as well as the patients. And obviously you have always finite resources, both time, your, basically all these, when a lot of patients are waiting, if you need to see an emergency, will they really, use their judgment and reasoning and their value system to basically see, is there a triage that works in those people? That is something very important. And very importantly is today, the present day mistrust is, there's a conflict of interest, will they really take care? So basically, we need to be a role model ourselves as teachers, because there is nothing, you can't really teach them with, textbooks. And basically, we need to define a document, how expected behavior. It should be written down. The SOPs and professionalism should be actually written down. And you can have workshops, and even role playing would actually work. And the proper feedbacks, you need to watch them. OSEX is a very great way of doing that. So basically, there are a lot of cultural differences. See, each person across India have different cultural upbringing, so that can actually also, it's rooted in that. And we actually, very unfortunately, have a lack of role models right there from the early MBBS days of orientation. We don't actually have professionalism in the curriculum rooted in. And there are students who are, the personality types matter. And not everybody is same. So obviously you can't expect that. There are people who actually do not really wish to be very rude, but they appear to be rude because that is their way of speaking or way of behaving. And obviously if you don't monitor, dandam dashagunam bhavet, if you don't have a penalization, if you don't have a monitoring, you can't expect anybody to be. So coming to the next part, this is something very important. Communication is everything in the today's context. In the Indian context, we need to really apply it to our type of patients, our kind of institutions where a postgraduate sees a lot of patients. There's a huge amount of outpatient that needs to be seen, a lot of OTs to be done. So then this communication takes a setback. We did not have a curriculum as such all these years. Now it has started in the present day CBME curriculum, but we didn't really have a curriculum for communication. And obviously it is from MBBS. The students are never taking history, they're not presenting cases enough. In internship, they just write, only documentation. They're not actually interacting much with patients. So this could be the reason why they are poor communicators. And that's why there's so much problem around all this. I'll just show you a small video. Like this could be...
Oh shit! Drop ho gaya, Apeksha.
This is a OT situation.
Drop ho gaya yaar.
Can you please do it?
हाँ. क्या करूँ अभी, क्या करना है?
बोला था ना तुझे छोटा एक्सेस नहीं करने को. हो गया ना अभी कॉम्प्लिकेशन. अभी क्या करेंगे? रुक, मैं वॉश होके आती हूँ फिर देख. Okay.
So basically, this can be still harsher. So you can actually use the local language. You can shout at the resident, shout at the junior. You can make the patient know exactly what has happened in the patient's own language. So basically, if you don't teach them, how to actually behave in the OT etiquettes is something that we need to see. See, look at this. This is a very standard thing that happens.
Not that photo on the Facebook or Instagram, please. Not that. Please crop me if you're putting that photo or edit something, do something, put some beauty face, do something. Okay, I'll get back to you in some time and I'll send you one more photo which you can put. चश्मा निकाल ली? क्या हुआ?
Multitasking.
आंखों से पानी जा रहा है डॉक्टर वो.
इधर आना एक बार. ये सब कब से हो रहा है?
10 दिन हो गए डॉक्टर.
हाँ, ठीक है. कुछ दवाइयाँ ले रहे क्या?
नहीं कुछ नहीं डॉक्टर.
Hello? Yeah, I've sent the photo which you should upload. Please upload that photo and all this one and tag me also. And do some nice editing work, please. एक minute, I'll get back to you.
So she worked out what she saw on the slit lamp. So she wants to come back.
सब शुरू हुआ बोल रहे हैं आप?
10 दिन हो गए डॉक्टर.
हाँ, ठीक है.
She doesn't know what to write because she has forgotten the clinical finding.
हाँ, ठीक है. हेलो. हाँ, how many likes did we get finally? हाँ, ये प्रिस्क्रिप्शन उधर लेके जाइए, वो एक्सटेंड करेंगे, ठीक है? हाँ, how many likes? We got some comments also. That's fun.
So basically, she would have probably done the right thing. She would have solely seen the clinical finding, given the right prescription. Maybe she has done her job correctly, but the patient is extremely dissatisfied. So this can be kind of a tool to show our postgraduates what not to do. So basically, like at the same time, they get to see sometimes patients with poor prognosis. No. how do you break the
क्या
bad
प्रॉब्लम है?
news?
मैडम बच्चा देखता ही नहीं है, मुझे पहचानता नहीं है, इतना टाइम हुआ, किसी को उसको बुलाते हैं तो भी देखता नहीं है।
नॉर्मल डिलीवरी हुआ था बच्चे का?
डिलीवरी नॉर्मल हुआ था मैडम, लेकिन रोया नहीं था बच्चा डिलीवरी के बाद।
फिट्स आया था?
फिर से एक दो बार आया था, डॉक्टर को दिखाए थे हम, उनने दवाई वगैरह चालू किया है, अभी तो ठीक है बच्चा।
तो बच्चा रोया नहीं, बच्चे को
हाँ।
फिट्स आया था। अरे ऐसे में ये ब्रेन पूरा डैमेज हो जाता है बच्चे का। ये आंख का प्रॉब्लम नहीं है मैडम, ये देख नहीं रहा है लेकिन फिर भी आंख में प्रॉब्लम नहीं, पूरा ब्रेन ही। बच्चे का गर्दन भी नहीं बैठा होगा अभी तक, तो ये चलेगा भी नहीं, बच्चा बैठेगा भी नहीं आगे। हमारा काम नहीं है ये ब्रेन के डॉक्टर को।
So I'll just show one more last video.
डॉक्टर एक्चुअली क्या हुआ,
Your PGs can really,
अच्छा दिख रहा था, अभी कुछ नहीं दिख रहा है, एक दिन से कुछ नहीं दिख रहा है, बहुत दर्द हो रहा है, बहुत दर्द हो रहा है।
the post-cataract sudden vision loss.
क्या हुआ डॉक्टर?
इन्फेक्शन हो गया आपको।
मुझे बहुत डर लग रहा है। इन्फेक्शन मतलब वही क्या, सेप्टिक?
हाँ वही जो हर बॉडी में हर जगह होता है इन्फेक्शन, वही आपको आंख को भी हो गया।
अभी क्या करना है डॉक्टर?
अभी
मुझे
क्या कर
नजर
सकते हैं, इन्फेक्शन तो हो गया। अरे वो बाद में सोचेंगे, अभी रुको, डॉक्टर आके देखेंगे आपको, देरी बैठिए।
So basically sensitizing our postgraduates to all such clinical scenarios. See, you can't expect them to learn the way how you need to communicate, handle these situations by themselves. So basically it's our duty as mentors to really show the right way. Okay, so maybe you need to show it, like you can probably show this video next to that.
मुझे एक्चुअली मुझे 3 दिन पहले ऑपरेशन हुआ था डॉक्टर, इस आँख का। तब अच्छा दिख रहा था, सब कुछ दिख रहा था। अभी एक दिन से कुछ भी नहीं दिख रहा है डॉक्टर, मुझे बहुत दर्द हो रहा है।
टेंशन मत लीजिए, एक मिनट यहाँ पे रखिए, इधर रखिए। डरने की कोई बात नहीं है, आप करेक्ट टाइम पे आए हैं, थोड़ा सा रिएक्शन हुआ है बस, करेक्ट टाइम पे आए हैं, टेंशन दर्द कम हो जाएगा, अभी ट्रीटमेंट देंगे, अभी बैठिए, अभी सीनियर डॉक्टर आके आपको देखेंगे, टेंशन मत लीजिए। पानी चाहिए आपको?
थैंक यू।
कुछ
So all these things probably can help them rather than giving a PPT on the entire communication skills or ask them to read about it. So basically at the end, so it's your individual assessment. You need to assess every student because their level of vocabulary, their elocution, their communication skills, their personality types, and their entire, the language problem. There are a lot of institutions where they cannot really communicate in the local language because they are from different states. So you need to basically observe the seniors, the mentors, the teachers, have to sit behind them and see how they actually talk to the patients and create this kind of a dry run. And there are specific contexts, what I showed you, like we need to really teach them how to break the bad news, how to soften the blow. At the same time, O6 is a great tool. You need to really sit behind them and see what they actually do in real world situation and do it. So basically, as I say, it's all about communication. If you want to really create a period where you have a peaceful, practice, patients are happy, and you have a well-rounded up ophthalmologist for the future, we need to work them on the communication and professional training. Thank you so much.
Any comments on this? Or is slowly hypoglycemia creeping up? Perhaps. Yeah, you have a comment, yes.
I totally agree with KP sir. What most of the students we see nowadays is like the lack of communication. This communication is very important because it builds a trust. So I work in a government medical college where a lot of poor patients come. A little pleasantries like how are you, or talk to them 2 lines politely and they will trust you. And so the entire procedure like treatment becomes very easy. Like they don't doubt your whatever treatment you give, or they'll accept whatever the result of your treatment is. So communication is very important. And one more thing is this, though not all, most of this aggression by the patients and attenders is because of the inappropriate communication by the medical professional,
the
I
junior
feel.
doctors.
Yes. So as soon as the patient enters, the way we talk to them, the way we interact with them, it will help to reduce all these assaults or whatever that aggression that occurs
So
on
we
the
are mentors, they are our
doctors.
tormentors. Yeah.
Yes.
All
No, I
right.
think it's whenever a patient says, I want to see the senior doctor, there is something wrong that has happened in the communication. Because sometimes a patient comes, he has been seen by probably a fellow, and patient asks for that fellow. He is not actually bothering about me, whether I'm there or not. That is a good sign that patient, because the seniority should show up. So obviously, we all our students, our fellows or residents, have that in their mind. They don't behave like a consultant. They have been trained to behave like a postgraduate only.
Yes, sir. So just a couple of things. First is language is a huge problem actually. We have many postgraduates from other parts of the country coming to Tamil Nadu. They have a lot of difficulty in communication. So it's not their fault, but we have to make that as a part of a curriculum to give them a training in the regional language. That's something what we do at Aravind. So we made a book called Essential Ophthalmic Tamil, got all the important Tamil words which are relevant for them to speak to the patients, and we made like audio video out of that. That's one thing. Second is that when I applied for UK, we have to pass an English proficiency test, something called as IELTS, which is very difficult to pass because it can be very generic in the way they ask the questions. Like, how was your day? That will be or you see a crying child on the road, what is your response? That will be the skills. But there is another thing called as OET, Occupational English Test, which is what I took, which is very easy because they're creating a healthcare simulation where the speaking skills will be, there'll be a patient and you will be the doctor. So the interaction is much easier. The way they grade the OETs, they have a checklist, how to score those, the candidates who apply for that. I saw that was so useful. Then I got all the flashcards and the assessment system. Then we are currently using in Aravind to train our postgraduates and our nurses on how to talk. This will be a great model. I would strongly recommend you to go and see the occupational English test, speaking models and how they assess that speaking skills.
Thank you, Pranish. Thank you, Dr. KP. We're going to conclude this session with an actual problem resident. Yes. No, not Rolika, is not the problem resident. She's going to be speaking about a problem resident's scenario number 1. And then we break for lunch.
Yeah, I'll take mine.
While she's setting up, I think one common problem that we've noticed across residents from undergrad, postgrad, fellowship, and it continues even in our practice, is the practice amongst us, and all of us are guilty of dehumanizing patients and referring to them as patients. And even while we are showing a colleague, we'll say, yeah, this patient is here. I mean, it's as simple as a case. Yeah, that case. And you call him that syphilis case, that sarcoid case. And yeah, exactly. So, and we don't even realize we are being wrong. And things like, dispose of these patients, check out these patients, or whatever we use. So that's something that we have to consciously make an attempt not to do, especially when we talk about.
They don't greet the patient. They don't ask, good morning, how are you, whatever.
Language was spoken of, but I think non-verbal communication is hugely important. Even if you are not able to communicate in the language, your empathy shows your attitude, how you meet and greet a patient, and so on and so forth. So I think that is a very important part, not just your showing it, but also looking at the cues from the patient of his non-verbal communication. These are very important in clinical practice.
I would like to be a little bit disruptive in terms of the communication. I don't know if this is something that resonates with you, but at least in Portugal it exists, and I think across Europe, but in my country and where I work, it exists. It's the definition of patient and the definition of client. And we can see that, for instance, if not all, at least several private groups of healthcare providers use this designation towards the patients, so they are the clients. And when we speak about clients, and this is something that I would like to know your approach to this, because when I went to medical school, to the Faculty of Medicine, I thought that I would be providing services for patients. I would be not a provider of services, but someone who would be there to help others who would benefit from my help. But for at least these last few 10 years, but last 5 years, this definition has been taking further strength in terms of defining the people who come to me for my services. So I see myself as a service provider for a client. And how this can affect our communication, knowing that on the other hand, for instance, we can see models in the business world that also employ empathy for providing the best service for their clients. So this is something that I would like, might be a little bit disruptive, but in terms of communication, this is something that we also have to prepare the residents to be equipped to do. Probably they don't feel so much this, because they are contemporary with this kind of approach and don't have so much the experience of the past. But anyway, I would like to know if you...
This is a huge issue, how the patient-doctor relationship has evolved. In India, in specific context, the Consumer Protection Act came in. And once it did, it altered the relationship of trust to a relationship of a provider and a receiver. And that has been a huge impact. I mean, over 45 years of whatever I've seen of practice of patients or ophthalmology, there's a huge change in the kind of trust and relationship and the kind of attitude that the provider or the physician at that time had towards the patient, of thinking of everything in terms of what is medically right and behaviorally right for the patient, to now a fairly much more protective mindset about making sure of looking at your back to make sure that nothing is happening. So there is a huge sea change in those 45 years of my practice.